Well, our Jupiter trial used a very powerful statin, rosuvastatin, at a pretty high dose, 20 milligrams, even though everybody started with a very low LDL cholesterol. So my intellectual bias is that potent statins at high doses, if they're effective for very low-risk patients, must be very effective for higher-risk patients. And my personal practice is I really don't titrate statin dose. I try to start with the highest dose of whichever statin that particular patient's health plan supports. But that being said, all statins lower LDL cholesterol, all statins lower CRP. They do so more reduction of both with regard to dose and across the potency of the classes. So the key issue here is patient compliance. Being on any statin is clearly superior to being on none, and none of the statins, whether they're potent or not, are going to be effective if the patient doesn't believe that taking the therapy day in and day out, year in and year out matters. So our job as physicians, we first must convince ourselves the intervention is required, and then communicate to our patients the importance of that. It makes no sense to write a prescription and have an argument about this statin or that statin if at the end of the day they're not taking it. And so I think we have a communication issue about this. As you know well, in a metabolic setting, it's very difficult to get a patient to take a medication that doesn't make them feel better. But we have to communicate that these agents are going to reduce your risk of heart attack, reduce your risk of stroke, extend your life. They're not a substitute for diet and exercise, but they really do work. And that's the real issue here.